The virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. This is your host, Paul Wirkus. We have had the great good fortune this month to be able to talk about all things measles with three people from the Division of Infectious Diseases in the Department of Pediatrics at the University of Utah. We've had Mary Fortini, T.W. Jones, and Andy Pavia. It's been very fascinating. We talked 2 weeks ago about measles, last week about the vaccine. And this week, in the face of some difficult circumstances, we wanted to talk about things that we ought to be doing to protect our patients in the climate of a current outbreak. Our lead this week is the estimable Andy Pavia. Welcome back, Andy.
Thanks, Paul. Good to be back.
You've been back often enough that I think you're one of our most repeated guests. And as soon as we get a merch store, we will have a ball cap with your face on it.
Okay, well, I'm going to have one that says keep kids safe again.
I mean, it's a big deal, isn't it? I mean, it's interesting because infectious diseases, I think, sits at the heart of what we all try to do in pediatrics, and that's keeping kids safe.
Yeah, absolutely. And we're in a very difficult time. I mean, we don't want to dwell there, but there are real challenges right now.
There are real challenges. I feel like we've introduced you often enough that it's just safe to say you've been here for a while. You've seen us all through some very difficult times, and you actually came to Utah first investing in outbreak. Isn't that right?
Yeah, way back in 1987, I was working at the CDC as an epidemic intelligence service officer, and one of the first really large outbreaks of E. coli infection with hemolytic uremic syndrome occurred in American Fork. And I came out, and with David Green and others who some people remember, we investigated that, found the source, and a year later, when CDC wanted to send me to a field station, my wife found a good job here at the University of Utah. So out we came, and we've been here for 37 years.
Yeah, I hope it was meant to be. You've been a pillar in the division and really have made a difference, and we appreciate it. Do you want to mention your disclosures again?
Sure. I have consulted for a company called Haleon, which makes over-the-counter products for viral infections. And I'm a editor of the Sanford Guide for Antimicrobial Therapy, so I receive royalties.
And that's such a valuable guide. TW and Mary, any disclosures you'd like to share with us?
I have no disclosures.
And I have no disclosures, financial or otherwise.
All right. So, Andy, in a remarkable time where we are not measles-free anymore, and we've talked about some of these things, at least tangentially, but I want to sort of formalize a little bit. We're recording this in the end of May. We haven't had any cases of measles in Utah, right?
No, and we've been quite fortunate since we're surrounded. Colorado has had cases, New Mexico's got a large outbreak, and Idaho just had their first case, although it was not an Idaho resident. So we're not safe, and it's probably just a matter of when, not if.
And given how extraordinarily contagious measles is, the likelihood is very high that a lot of people will encounter it and that someone may not have the immunity to be able to resist it.
So our risk of bringing measles back to Utah has been there for a long time because a lot of the world still has measles outbreaks. And for the last several years, there's been a lot of measles in Europe. There's always measles in parts of Africa. This year, it's really struck all of North America. So there's over 1,000 cases in Canada, over 1,000 in Mexico, and well over 1,000 in the US right now. So the possibility that somebody with less than complete immunity travels from Utah or travels to Utah and brings us measles is really high.
Well, let's talk about what we ought to do then. First of all, how do we ensure that someone is adequately immunized?
So full protection comes from getting 2 doses of MMR vaccine at least 28 days apart. And I think most of the audience are pediatricians, so you're used to giving the vaccine to your patients between 12 and 15 months, and then typically then at the 5-year visit before school entry. But that's really something we've just done for convenience because it works with the vaccine schedule and the visit schedule. So one of the things that can be done right now is to accelerate that second dose. The CDC, of course, is a little bit hamstrung in what they can say, but even they are being quite vehement that if your child is traveling overseas or to an area with a known outbreak, you should go ahead and get their second dose as soon as they're eligible, so at least 28 days after the first dose. We do know that there's a slightly better immune response at 3 months versus 28 days. So today, May 30th, without measles in Utah, you might want to just say, hey, we'll do the second dose at the 15-month or the 18-month visit. Once we have widespread measles in Utah, which God forbid we have, then you may want to just use the 28-day rule.
And is there any disadvantage to that? You said it's been a matter of convenience that we've done it at the kindergarten visit until now. Is there any advantage to waiting that long or serving children just as well by aiming for 15 or 18 months?
I think if we go for 15 or 18 months from the studies that have been done so far that I've read, it's every bit as good as waiting till 5 years. Naturally, the immune system undergoes something called affinity maturation of B cell responses. And so boosting actually for many diseases is more effective if the interval is 3 to 6 months after the first exposure, which is why I think right now, if you have the choice, waiting to 15 months or 18 months makes some sense. But the response is really good if it's as little as 28 days out. So that's a very viable option. And particularly if you're going to Texas or North Dakota, France, Canada, Mexico this summer, you want your kids to be fully immunized.
Are there kids who ought to be getting the first dose before age 1?
Great question. There is a recommendation that you can give an extra dose between 6 months and 12 months. It doesn't count for long-term immunity, so you still are going to have to get 2 doses. That's something that you really should seriously consider if your child's going to be at significant risk. Remember that young kids are the ones who get sickest with measles, so you don't want your 7-month-old to get measles. They're more likely to end up in the hospital than your 6-year-old. So who should we do that for? Probably the same group that we just talked about, traveling overseas, traveling to areas of known outbreaks. So right now that would be the provinces of Alberta and Eastern Canada, as well as Mexico, and then the less developed parts of the country like Texas.
This extra dose and accelerated dosing that Andy's talking about was literally what I did with my second daughter because we had her in the 2018, 2019. We had her in 2018. And if you remember the 2018, 2019 season, there was a large outbreak of measles all across the United States at that time as well. The numbers were really high prior to COVID. And so we, just like he's describing, we got her first dose of measles vaccine when she was 6 months old. And then we wound up doing the accelerated, getting her what would have been the second dose, right when she was 1, and then the third dose only about a month after that. And when I've talked to a lot of other pediatric infectious disease providers who have young children, this is exactly the schedule a lot of them are following as well, especially given the current climate.
In countries where many kids die of measles, particularly in Africa and parts of Asia, WHO recommends the first dose of measles to be given at 9 months rather than 12 because the chance of your dying in that period between 9 and 12 months is pretty high. The loss of efficacy between 9 and 12 months is very small, but it's real, it's measurable. The loss of efficacy, if you get your first dose between 6 and 9 months, is quite a bit bigger. And that's why in the US we have the luxury of making sure everyone gets optimally immunized. If you get an early dose, you still should get 2 doses.
Just as a brief side note, so it seems that there are 2 distinct sort of risk areas in the world, that there are parts of the world where there's lack of access to vaccine. And then is the issue in Canada and France, for instance, similar to ours, so that people opting out of the vaccine?
Very much so. They have seen the same phenomenon that we have, England as well, where there's been a drop in vaccine confidence. And so a decrease in the levels of immunization among young children. And as we talked about in previous episodes, as Mary was talking about, it doesn't take a very large drop in the coverage rate for a population to become susceptible to the spread of measles again.
Yeah, when you're talking about a 95% need for herd immunity, that's a fairly high standard and speaks to the fact that we've done it before and, hoping that we can muster the will to do it again. What, if anything, can I do? And we talked about this a little bit with TW last week. There are some people who say, well, I want to get the vaccine, but I want to adjust the timing. And we talked about the objections and about the sorts of things that concern people last week. Any advice about what we ought to do about that, Andy?
So the question that I think you're sometimes faced with is, you want to give them all these vaccines. That seems like too many. Can't we space them out? And I think, as pediatricians, we need to be sensitive to parents' concerns and receptive, at least my approach. And remember, I'm not a primary care doc, so I don't have these conversations as often as you guys do, but is to say, well, let's think about what's most important at this age. So getting protected against measles right now on time is probably number one. Getting protected against Haemophilus influenza and against pneumococcus are also really important because, that risk starts very early in life, and that's pretty high. Paul, I don't know if you're old enough to remember Haemophilus influenza B. It was around at the beginning of my medical career, and about once a week we would admit a child with overwhelming meningitis due to Hib. That disease isn't with us anymore, but it could come back as well.
It's just before my time, but it's an example I use all the time with families. This is a disease you've never heard of, but you can't believe how bad it was in a very recent period.
Yeah. And then I think, if you have to negotiate, there are vaccines like varicella, which are useful, but the benefit is not nearly as large as it is for the ones we just talked about.
I think that's really helpful. So we talked last week about concerns that people have with the vaccine. Let's talk about some alternative recommendations that we've heard in terms of how to deal with the measles. Let's start with a natural immunity is better than immunization immunity. So why don't we just make sure the kids get it?
Yeah, that's one of the most dangerous things that our current Secretary of Health has said, and there's a lot of competition for dangerous things that he's said. The immunity from natural infection and the immunity from 2 doses of vaccine appear to be pretty similar. They both are lifelong. They're both very high level. There are no studies that I know of that have been able to show any daylight between them. But if you get the vaccine, it's very safe. We talked about side effects last week. They're relatively mild and quite uncommon. If you get the actual infection, your kid's going to be about as sick as you've ever seen if they've got a quote-unquote mild case of measles, and they run a 1 in 5 chance of ending up in the hospital. And then, as Mary talked about a couple weeks ago, there are these really dangerous complications of getting measles. Do you want protection from snake bite by letting rattlesnakes bite you every couple of weeks? Or would you rather get a vaccine to protect you or wear high boots?
So there's no difference between the immunity that you get from the shot and the immunity you get from the disease.
None that's really been able to be teased apart. There may be some subtleties, but the studies have not really been able to show that post-infection immunity is better than vaccine immunity. I kind of hate the term natural immunity because both types of immunity are totally natural. It's your body responding the way it knows how to do to exposure to an antigen to help protect you. One is caused by an infection that might make you really sick, and the other is caused by a vaccine that has only a very low chance of causing any side effects.
Yeah. How about vitamin A? There are some patients who benefit from vitamin A, correct?
What we know about vitamin A is that in studies that have been done in populations with a really high prevalence of malnutrition and a vitamin A deficiency, administration of vitamin A has shown some benefit when given to a child who has measles to decrease the risk of blindness or pneumonia. There are no studies that have ever shown a benefit in a well-nourished population like ours. However, doses of vitamin A that are carefully calculated, that are given under doctor's supervision if you have measles, probably can't hurt, might have some benefit, and we recommend it, at least for hospitalized kids, and some authorities recommend it for any child with measles. What's dangerous, though, is to use vitamin A to prevent measles. First off, it does not work. Secondly, vitamin A accumulates in the body, as most people know, and it has a fairly low therapeutic index. So you can get vitamin A toxicity in a small child relatively easily by giving them supplements of preformed vitamin A.
This is not like megadoses of vitamin C.
Yeah, you can take vitamin C until it burns when you pee and you get a kidney stone, and that's about all that can happen. But vitamin A, vitamin D, the fat-soluble vitamins have a fairly tight therapeutic index. Now, there's some confusion about this because the precursors to the retinoids, so beta-carotene and others, don't accumulate in the liver. It's the stuff that you would get in animal products like cod liver oil or in a supplement that are preformed vitamin A, and those are the ones that accumulate and can cause toxicity. You probably heard that pediatricians in Texas and elsewhere have, for the first time really in their lifetime, seen a number of kids with vitamin A toxicity, sometimes serious.
I remember I saw it once during my training in the ICU, and it was something to reckon with. What about other fringe or unproven treatments? I'm sure you hear about stuff.
Yeah, it's probably worth addressing the ones that Secretary Kennedy has mentioned because they are potentially dangerous. There's no data whatsoever suggesting they're useful, but because it comes from an appointed member of the government and because there are people who listen to what he has had to say, I think there's a lot of interest that's gone on in social media. So he's talked about use of a combination of budesonide, a steroid, clarithromycin, an antibiotic that we don't use very much because it has a high rate of side effects, and cod liver oil as a treatment for measles. It doesn't work. The budesonide probably further reduces your immune response when you've already got a virus that's attacking your immune system. And clarithromycin is an antibiotic that you don't need that is going to cause stomach upset in just about everybody, and of course, run some risk of resistance to azithromycin and other related compounds when you take it unnecessarily. So it's a dangerous recommendation that has no basis in science.
Anything else we ought to be avoiding?
I think those are the big ones. People should be very careful about treating their children with vitamin A without really understanding the appropriate dose. The recommended doses are weight-based and age-based for children. It ranges from 25,000 units to 100,000 units. There's two different ways that we count retinols, which makes it confusing. This is not a good one to go into the supplement section of your grocery store and purchase. I'm certainly not against giving your kids vitamins. I think that's a reasonable thing to do in many settings, but vitamin A is really not one to mess around with.
Clearly not a case of if a little is good, a lot is better.
Yeah, if you have a diet that is high in carotenoids, so orange-colored vegetables, you have plenty of vitamin A available and you don't need any supplements. If
Don't you
you're a
think
child in Africa living entirely on fufu and no access to fresh vegetables, then vitamin A is a real problem. Same thing's true in parts of Asia.
Sure. Don't you think that one thing that has had some influence on this is as we came through the COVID pandemic, that fortunately, while children were clearly affected, they weren't necessarily affected to the extent that the elderly were and that adults were. And I think that has given people sort of a false sense of safety with an outbreak like this.
I think that's probably true. First off, I want to address the myth that COVID wasn't bad for kids. It was
Right.
horrible for adults and the elderly, but for kids, it was no treat. And we
Right.
lost roughly 2,000 children to COVID in the U.S. through
Mhm.
2024. 2,000 kids, that's about 3 to 4 times as many kids as died from influenza. So, that was a relatively big deal. But it is important to realize that measles is a disease that is very rough on younger children, those under 5, particularly those under 1 year of age, which is different than a disease that largely targets the elderly, which COVID was.
And, I think that when we have the conversation, as we were mentioning last week, it behooves us to have compassionate conversations with people. I think that most people feel that they would do anything to keep their child safe. And I think it's unfortunate we live in an era where I think there is this sort of false equivalency between I want to keep my children safe from vaccines and I want to keep my children safe from diseases. And I think that's an equivalency that we really need to be able to address rationally and compassionately.
Yeah, we need to understand that the way we're wired to think is that you feel much more guilty about something you do than something you didn't do. People got very worried about the half dozen people or dozen people who would get injured by seatbelts and crashes and not weigh that against the 30,000 lives saved by the use of
Right.
seatbelts.
Right.
Same thing is true with airbags. And that's really understandable. If I give my child something and they're one of those few children who has a side effect, I'm going to feel terrible because I chose to do it. And yet you don't realize that if I don't give my kid this vaccine, their chance of something bad happening to them are dozens of times or hundreds of times higher. But they feel different. I mean, just the way we think as parents, as humans. And we need to acknowledge that and maybe even say it out loud. Subjecting your kid to a tiny risk from something you choose to do feels worse than subjecting them to a large risk by not doing it.
And I
But
think
that doesn't make sense.
I think the way that we both propagate and consume information is so much in silos that I think it becomes increasingly difficult to do your own research because I think it's harder for people to find the objective source that gives them the pluses and minuses. And so it almost feels sometimes that when people talk about vaccine injuries, it's almost as if they know someone this happened to, even if it's something that they saw shared on social media because it feels personal somehow. And I think that frustrates all of us who try to do this is that science works and that faith in science has eroded in very unusual ways over the last few years.
Yeah, it has. And we have to take some responsibility for that. We didn't communicate well enough that the nature of science is things were going to change. We didn't know that COVID was truly airborne. And
Right.
so our initial advice didn't talk about that. We didn't know that you couldn't get it from the Amazon package that somebody had handled. So people wiped down their Amazon packages and we changed our recommendations as we learned more. But we didn't communicate that was going to happen. And we weren't humble enough about that. So people lost some faith that way. The other thing that I hear from expert communicators, people who teach us how to communicate, is to remember that we're humans, we're used to sitting around the campfire and telling stories. That's what matters. To those of us with scientific training, numbers and data are really important. But even for us with that training, stories have a lot of impact. So I try and tell the story of how when the Haemophilus influenza type B vaccine came out, and my daughter was 9 months old, I made sure she got the first dose that any child in Utah got of the vaccine because I was so worried about her getting it. I think that sort of story, that personal connection makes a big difference, you know. It's worth saying, look, I understand where you're coming from. I'm a parent too, but I've thought about all this really hard and my kids have gotten every vaccine and I feel really good about it.
Right. And I think that as we develop a strong, compassionate connections with our patients and with their families, that makes a difference. And I think the way that we talk about things can be real compassion then.
And I think we're not keeping up with the changes in communications. These days, our parents are in their 20s are getting most of their information from social media. We're not out there on social media trying to get the good information out. So the misinformation spreads. And of course, you trust your friends. So if somebody in your Facebook group says, I know that my cousin's friend's uncle got the flu vaccine and then he had a car accident. So the flu vaccine caused the car accident. I'm being facetious, but maybe he got Guillain-Barré. That has a lot of impact. Whereas saying that Mary and TW and I saw kids on ECMO in the ICU for weeks at a time because of complications of influenza isn't out there on Facebook for people or on other social media.
Yeah,
Right.
social media and streaming services really give a false sense of proximity to a lot of celebrities or influencers. And so, oddly, I think a parent who's watching somebody like Liver King who's telling you to eat raw meat and avoid modern medical practices actually oddly feels more real to a lot of people than having a conversation in a pediatrician's office, especially if that conversation lasts less than 5 minutes and they don't get their questions answered. That phenomenon of social media makes you feel like you made a connection with somebody who has no connection to you whatsoever, but can propagate all kinds of insane beliefs.
Right.
And in a world of influencers, all influencers seem the same. Whether it's Paul Offit telling you about why vaccines are helpful, or somebody from the Children's Defense Fund that RFK used to run telling you that vaccines are the cause of all evil.
Hey, but you guys are on a podcast, so that's pretty great.
That's true. Waiting
Andy,
for your YouTube channel, Paul.
any other resources that we ought to be looking toward, or any other information you think we ought to?
Well, one thing I think we all try and do with our patients and their families is try to say that it's really good to educate yourself. We don't want to go back to the days of saying, I'm the doctor and I told you so. We want people to understand their health and take an active role in it. But we need to help point them to good sources of information and remind them that, don't get health information from Facebook or some random something that shows up in your feed. Go to WebMD, go to the Mayo Clinic, go to the University of Utah, the Utah Department of Health. Go to reliable sources and do your reading. Don't just see what pops up at the top of your Google feed.
I just wanted to add another great resource. The Children's Hospital of Philadelphia, or CHOP, actually has a really good website specifically for vaccines. It's, I believe, called the CHOP Vaccine Education Center, where parents can go to if they have any questions as far as the ingredients for some of the vaccines that they're concerned about. It is a great resource, so definitely would recommend that.
Super.
Yeah. I think for pediatricians to have a website or some sort of media presence, one of the things that would be a great idea, I haven't seen it, is to put a list of trusted sources. Do your own research, but here's some good places to go.
Right. Yeah, that's a great idea. All right. Well, there's a lot to think about, and hope we can keep kids safe through all of the variables. Thanks for your time. For those of you who have questions, please send your question to vcurb.com. Make sure and tell your friends and neighbors and people you like and people you don't like to listen. Thanks to Elisa Stoddard for being this guest, and thanks, Janice, for listening. We'll talk to you next week.
Thanks, Paul. Thanks for having us.
Thank you.
Thanks. Thanks for joining us. We look forward to getting together again next time. The virtual Curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design, thanks to Phil Wirkus, who also composed the theme music. See you next time.